Treating patients in suicide risk is a complex and difficult task, and it's filled with uncertainties. It is not possible to predict suicide at the individual level, and there are no tools for doing so. So dealing with this uncertainty leaves healthcare professionals constantly alert, leaving the work feeling worried. What I did find when I interviewed suicidal patients and healthcare professionals across 9 inpatient settings was that how the wards dealt with this uncertainty matters for patient safety. In the unsafe wards, healthcare professionals were driven by fear. They were feared being held accountable for a patient's suicide and being scapegoats. And they were excessively preoccupied by avoiding these errors and covering their own backs and excessively documenting information in the patient's journal, or simply also transferring the responsibility for the patients to another person or to another ward. In these unsafe wards, the suicidal patients experienced that the healthcare professionals did not see them as an individual, did not contain their pain, and that they were merely asking questions and ticking off boxes. Some of the patients felt an increased sense of hopelessness and shameful for having their emotions, and felt that encountering such interactions also increased their suicidality while being hospitalized for a suicidal crisis. So what characterized the opposite, the psychologically safe wards? First of all, it was a matter of management. None of the wards managed to get to a point where patients and healthcare professionals felt psychologically safe without having safety built into the structure and the culture of the ward. The clue was to organize systems to cope with uncertainty. Healthcare professionals needed to be able to cope with the uncertainty of working with suicidal patients on a daily basis. And to do so, they needed each other. They needed a culture of mutual support and trust in which they felt safe enough to be vulnerable, to be unsure, and to discuss with their colleagues. When feeling safe, they could better contain patients' emotions, anger, and fear. Several structures were mentioned to fulfill this purpose. Clinical supervision at a regular basis. Informal support, ad hoc support, or basically having friends and informal networks at the workplace. Debriefing after incidents. Daily meetings with their colleagues to ensure they were on the same path with the patient, and collecting patient feedback to ensure they were on the right track. Basically, this case study suggests that for patients to feel safe, healthcare professionals need to feel safe. In the suicide context, safety is not only something that is implemented, it is something that is also created in the interpersonal meetings between individuals. For suicidal patients to be safe, they also need to feel safe. And to create psychologically safe wards, you need patient safety strategies and ward cultures, which ensures that healthcare professionals are supported. And you need structures ensuring that you're on the right track with the patient at the main focus of the care.